Welcome to Around the Couch. I'm Jeff Callis from Kidney Couch. In this episode, I talk about whether there is a need for periodic imaging 5 years after a partial or complete nephrectomy. The recommended guidelines for surveillance of patients following a nephrectomy within the first 5 years is fairly standard in the medical profession. Keep in mind these are only guidelines and not absolutes. Your physician needs to consider your unique medical condition, cancer type, stage, and grade when setting you up on a surveillance schedule. And it may change in the future based on the findings of imaging in the future or your medical condition. The most frequently followed guidelines within the first 5 years are, for patients who have had a nephrectomy, the urologist or oncologist will usually schedule a CT scan or an MRI 3 months after your nephrectomy. The information from these images is used for comparison to future imaging to look for any changes. A new baseline. The same is true if a patient had other parts of the body involved, like the lungs or lymph nodes. Mayo Clinic uses the following guidelines as recommendations for surveillance following a partial or complete nephrectomy. Mayo uses the Leibovich model that was developed by Dr. Brad Leibovich and Dr. John Cheville, an anatomic pathologist, as well as others at Mayo Clinic. The model was first developed in year 2003 and then updated later with additional input criteria in 2018. Based on my research, the recommendations seem to be the standard for most physicians and medical centers when monitoring for kidney cancer recurrence after a nephrectomy. For all risk groups, patients have a CT or an MRI 3 months after the nephrectomy to establish a new baseline for comparison against future imaging. For patients with low risk of cancer coming back, if your physician is using the Leibovich prognostic model, low risk means you have a progression-free survival score between 0 and 2. Progression-free means kidney cancer has not returned since the patient had a nephrectomy. You will likely have a CT scan or an MRI of the abdomen and pelvis, as well as a chest X-ray, annually for 5 years after surgery, and after 5 years, a renal ultrasound and a chest X-ray. For intermediate risk of cancer coming back, if your physician is using the Leibovich prognostic model, intermediate risk means you have a progression-free survival score between 3 and 5. Intermediate risk is defined as cancer that has a moderate likelihood of returning or progressing. If the risk of cancer coming back is intermediate, you will likely have a CT scan or an MRI of the abdomen and pelvis and a CT of the chest or a chest X-ray every 6 months for the first 3 years, and then annually after 3 years for years 4 and 5. My score using the Leibovich model was a 5, so I fit in this category. I'm considered a high intermediate risk for recurrence of renal cell carcinoma within 5 years. I had baseline imaging 3 months after my nephrectomy and have had imaging every 6 months for the first 3 years so far. In November of 2025, I will have had my 6th surveillance exam. February 2026 will be my 3-year mark since having a complete nephrectomy. Because there has been no detectable return of renal cell carcinoma on imaging or any other symptoms, I expect I'll be having annual surveillance testing rather than every 6 months, starting in February. I've not discussed with my urologist as to what will happen when I do reach the 5-year mark at this point. That will have to wait and will depend upon the results of imaging and lab testing over the next 2+ years. For high risk of cancer coming back, high risk is defined as having the highest risk of cancer returning based on the stage, grade, and other medical conditions that the patient has. If your physician is using the Leibovitz prognostic model, high risk means you have a progression-free survival score greater than or equal to 6. If the risk of cancer coming back is high, you'll be closely monitored and have a CT scan or an MRI of the abdomen and pelvis, as well as a CT of the chest or a chest X-ray at 4-month intervals for the first 2 years, then at 6-month intervals for years 3 to 5, and then annually after 5 years. For patients with advanced cancer, otherwise called stage 4, or the kidney cancer was not completely removed during the nephrectomy, you and your physician will decide together how often you need to be seen in follow-up. This will depend on any treatment you may need to help control the cancer or any symptoms that you may have. As you can see from these guidelines, the higher the stage and grade of renal cell carcinoma that a patient has, the more frequently is the recommended follow-up imaging and testing. That's just common sense. The higher the risk of cancer returning, the more frequently a patient is monitored with imaging in the future. Some prognostic predictive models for recurrence after a nephrectomy are used to determine a patient's risk of the cancer returning. In addition to calculating a percentage for recurrence, patients are classified as being low, intermediate, or high risk. In my case, because my renal cell carcinoma was 5 centimeters in size, it was stage 3, grade 3, with renal vein invasion, I am considered a high intermediate risk for the cancer returning. My urologist uses the Leibovitz model to make this determination. There are other predictive models out there, but I mention the Leibovitz model because I'm familiar with it and my urologist uses it. Using the Leibovitz model, the prediction of kidney cancer not returning after my nephrectomy within 5 years is 75%. Within 10 years, it is estimated to be 67%. When I first read that, I interpreted that to mean that my risk of kidney cancer returning was greater with each passing year. But that's not what these numbers mean. It is confusing, to be sure. This is what I've learned from the research that I've done to better understand it. It means that the cumulative percentage of people who have a recurrence increases over time, but the risk of recurrence typically decreases as more time passes without the cancer returning. So more specifically, at 5 years, for me, with my score and intermediate risk, 75% of patients have not had a recurrence. This means that 25% of patients have experienced a recurrence within the first 5 years. At 10 years, 67% of patients have not had a recurrence. This means that 33% of patients have experienced a recurrence within the first 10 years. The difference between the 5-year and the 10-year mark in my case is 8%. 33% in year 10 minus 25% in year 5 equals 8%. That represents the number of additional patients who experienced a recurrence between years 5 and 10. The rate of recurrence is higher in the first 5 years. 25% over 5 years is an average of 5% per year, compared to the period between 5 and 10 years, which is 8% over 5 years, is an average of 1.6% per year. This indicates the risk of recurrence generally decreases over time for kidney cancer. For most cancers, including kidney cancer, the greatest risk of recurrence is within the first few years after treatment, usually within the first 2 to 5 years. While late recurrences, meaning after 5 or even 10 years, can happen, they are less common. So in short, the risk is not getting higher each year. Rather, the longer the time period you look at, the more opportunities there are for recurrence to occur in the overall patient population, even as the risk in any single later year actually goes down. I searched the World Wide Web to see if there was agreement on imaging guidelines after 5 years from having a nephrectomy. The AI overview results came back with this summary. Follow-up imaging more than 5 years after a nephrectomy is not mandatory, but it is recommended for intermediate and high-risk patients based on physician and patient judgment. Guidelines vary, with some suggesting CT scans every 2 years for high-risk patients, while others recommend continued annual imaging up to 10 years for younger patients. Decisions are made on an individual basis, weighing the risk of late recurrence against the potential downsides of radiation exposure and cost. And again, late recurrence refers to cancer that has returned after the 5-year mark. That summary fits well with information that I have seen over the past 3 years from medical institutions and from kidney cancer organizations who take up this question from time to time. It's a question that has been on my mind for the past 3 years as I've walked this, at times, crooked path. When my physician first presented me with the recommended guidelines for imaging in the future, it only covered the first 5 years. So I asked, what happens after 5 years? The response from my urologist was, we'll determine that when the time comes. Now, almost 3 years later, that makes more sense to me. Many factors need to be taken into consideration when determining what the surveillance plan will be after 5 years of being kidney cancer free. And notably, each patient is different. At first, that didn't make me very comfortable. Was I not going to make it 5 years, so don't worry about it? Or was there a lot to be learned within the first 5 years before a recommendation could be made? Up to this point, having imaging every 6 months has been sort of a comfort blanket for me. I get anxious as hell 2 weeks before the CT scan, but when it's over, I'm glad to get the good news that the ugly beast has not reared its head again. But how will I feel if I just stop having imaging on at least an annual basis? Will I worry if I don't have a CT scan? Of course I will. That's just my nature. But will I be worried sick? Will I be one of the worried well? In my case, I had no symptoms from anywhere from 5 to 15 years before I was diagnosed with kidney cancer. The only reason it was detected was because I had a CT scan looking for kidney stones. There were no alarm bells going off. If I don't have a CT scan every once in a while, how will I know if the cancer has returned? Why would now be any different? Because a kidney cancer can return at any time, it stands to reason that I will have to have periodic CT scans for the rest of my life, although less frequently, I would imagine. As time has passed, I'm more comfortable with that and what will happen after the 5-year mark. As I've learned from others and doing some research, it really is patient-specific as to what kind and how frequently I will be monitored after 5 years. The National Institute of Health tells us this about the factors influencing long-term follow-up. 1. Risk of recurrence. Patients with intermediate to high risk factors, such as certain tumor types or stages, may benefit from continued monitoring. 2. Patient preference. After the initial 5-year period, the decision often involves a discussion between the patient and their physician to weigh the risks and benefits of continuing scans. And 3. Individual case specifics. Factors like age, tumor grade, and type are used to assess long-term risk, though no kidney cancer predictive model definitively predicts late recurrence after 5 years. Whether you need imaging more than 5 years after nephrectomy depends on your individual risk factors. Many guidelines recommend stopping routine surveillance after 5 years, while acknowledging that late recurrences can occur. Well, that doesn't sit well with me. No one can tell me why I got kidney cancer in the first place, and I don't seem to have a very good understanding of whether it will return either, whether it's within 5 or 10 years. So, as a patient, I'm not comfortable with stopping all periodic imaging. I think it's medically indicated to do so as a high intermediate risk patient. For patients who are low risk, I can understand discontinuing testing as frequently as you have within 5 years. If you are intermediate or high risk, it makes sense to me to continue monitoring with imaging at least every 2 years. Then at some point, based on a patient's age, stopping imaging on a schedule seems to make sense. Having imaging when there are clear symptoms instead makes sense too. But as I've experienced, many times there are no symptoms with renal cell carcinoma, so no monitoring at all, even after 10 years, doesn't make a lot of sense to me. It also depends on a patient's age. The younger a patient is, the better the case for continuing surveillance imaging beyond 5 years to catch any return of cancer early and have a better prognosis. In my case, I'm approaching 65 years of age. At some point, depending upon my overall health, having a CT scan won't be that important to me. If I'm 80 years old, something else may kill me sooner than kidney cancer might. But I'm not putting that on a schedule either. In the end, intermediate to high-risk patients are likely to be advised to continue imaging based on physician judgment and patient preference. The decision to continue imaging beyond 5 years is made on a case-by-case basis, weighing the benefits against the risks of repeated scans and the potential for late recurrence. Of course, the final decision rests with the patient. At this point, I'm leaning towards continuing imaging well beyond the 5-year mark. I'm waiting for a few grandkids to start coming. I don't want to miss that. And our puppy Remy thinks she's spoiled. Just you wait. When you're approaching the 5-year mark, have a detailed discussion with your physician, your urologist or oncologist, will consider your specific situation, your personal risk profile. Make sure you do your homework and understand your risk profile, using the results from a kidney cancer predictive model, so you have a good understanding of what your risk of recurrence is, whether it's low, intermediate, or high. As the saying goes, your physician cannot care more about your health than you do. Do your research and understand what the best plan for you going forward is, and not depend on your physician to just tell you what you should do. Armed with that information, your physician can help you understand the recommendations for your specific case and create a personalized follow-up plan for you. To help formulate a plan after 5 years, I've done some research regarding what the top 5 medical centers for the treatment of renal cell carcinoma in the United States recommend for follow-up imaging more than 5 years after a nephrectomy. I looked at the recommendations from MD Anderson, Memorial Sloan Kettering, Mayo Clinic, City of Hope Cancer Center, and Massachusetts General. Since they are the top 5 for kidney cancer, the best of the best, it makes sense to give some weight to what they recommend. At least I think so. It's noted that about 10% of renal cell carcinoma recurrences can happen more than 5 years after surgery. So many clinicians continue some form of follow-up to detect these late recurrences. 10% is not insignificant. There is consensus among these top 5 medical centers on these 16 points. Consistent with major urological guidelines from the American Urological Association and the National Comprehensive Cancer Network, it is recommended that follow-up imaging more than 5 years after a nephrectomy be individualized based on the patient's original cancer risk factors. After 5 years, the decision to continue imaging is a discussion between the patient and their physician, weighing the potential benefits of early detection against factors like radiation exposure, cost, and patient preference. There is no single standard protocol for all patients. While most recurrences happen within the first 3 to 5 years, renal cell carcinoma is known to have late recurrences, or more than 5 years after surgery, in about 10% of patients, highlighting the need for prolonged monitoring in some cases. The intensity and duration of follow-up exams are directly tied to the initial tumor stage, tumor size, and grade. For patients at low risk of recurrence, imaging beyond 5 years may be discontinued or performed only as clinically indicated, such as if new symptoms should arise. For patients at intermediate or high risk, annual imaging may continue for up to 10 years or more due to the possibility of late recurrence. The specific surveillance schedule is determined by the patient's individual risk profile, which can be assessed using a predictive model. For intermediate and high-risk patients, abdominal imaging, such as a CT scan or an MRI, every 2 years beyond year 5 up to year 10 is recommended. The decision to continue imaging surveillance beyond 5 years is based on the patient's specific risk factors, such as tumor stage, histology, and other clinical indicators. For patients with a history of moderate to high-risk disease, continued imaging is more likely. The surveillance plan is at the discretion of the clinical team, typically involving a physical exam and blood testing, imaging, such as a chest X-ray or a CT scan or an MRI of the abdomen and pelvis, especially for patients with a history of higher risk disease. Imaging is always recommended if the patient develops symptoms suggestive of recurrence or metastatic spread. High-risk patients, defined as higher stages 2 to 4, or for tumors that spread to the lymph nodes, have a higher chance of late recurrence and may require continued annual imaging, sometimes up to 10 years or more at the discretion of the clinician. Low-risk patients, defined as stage 1, typically have a reduced need for intensive surveillance, and imaging beyond 5 years may be optional or discontinued. Abdominal imaging with a CT scan or an MRI are generally preferred for sensitivity, but an ultrasound can be used in low-risk patients to reduce radiation exposure. And finally, number 16, long-term follow-up also includes monitoring the function of the remaining kidney through regular blood pressure checks, blood testing, specifically for creatinine to assess the eGFR level, and general health management. In summary then, after 5 years, the follow-up imaging for a nephrectomy is determined on a case-by-case basis through a shared decision-making between the patient and their physician. The risks of late recurrence means that some patients, especially those at higher risk, may still require periodic imaging, such as CT scans of the abdomen and chest, at the discretion of their physician. These top 5 medical centers in the United States are consistent with their recommendations for the most part. Having ongoing follow-up for the first 10 years after nephrectomy is recommended for patients who are at an intermediate or high risk for recurrence. A study by the Yonsei University College of Medicine in Korea titled Incidence and Pattern of Recurrence After Surgical Resection in Organ-Confined Renal Cell Carcinoma, published in November 2024, took a closer look at the question of whether surveillance for renal cell carcinoma for stage 1 and stage 2 tumors, those considered low risk for recurrence, should be done. Their study found that localized renal cell carcinoma recurs within 5 years in approximately 20 to 30% of patients, even after curative treatment. Therefore, several guidelines recommend regular follow-ups for up to 5 years. However, the decision to follow up after 5 years is usually based on the patient's preference or the physician's judgment. For follow-up beyond 5 years after surgery for renal cell carcinoma, the European Association of Urology guidelines recommend a CT every 2 years for intermediate and high-risk patients. The National Comprehensive Cancer Network guidelines recommend risk-based follow-up, but do not specify the frequency of follow-up or what tests should be performed. The American Urological Association guidelines recommend that abdominal and chest imaging follow-up in high-risk patients should be determined through informed decision-making discussion. Among the most diverse prognostic factors in renal cell carcinoma, the pathologic stage is one of the strongest and most important prognostic factors. Consequently, the higher the stage, the worse the oncologic outcome. Stage 1 renal cell carcinoma has a 5-year survival rate of about 90%. However, even small renal cell carcinoma may not always have a good prognosis. Patients with stage 1 renal cell carcinoma can experience cancer-specific death even after 10 years. Based on this, it would be difficult to conclude that the recurrence rate at 5 years after surgery is so low that it can be ignored in patients with stage 1 and stage 2 renal cell carcinoma. In stage 1A, the average annualized recurrence rate after 5 years was 0.5%, which was not significantly different from the recurrence rate before 5 years. For stage 1B and stage 2, the average annualized recurrence rates after 5 years were approximately 3% and 3.1% respectively. Although those rates were lower than the recurrence rates within 5 years of surgery, they were not insignificant. The follow-up interval may be an important decision during follow-up after surgery for renal cell carcinoma. The European Association of Urology and the American Urological Association guidelines suggest that follow-up examinations should be performed every 2 years between 5 to 10 years post-operatively. The early detection of recurrence is important for improving treatment outcomes. However, it is not efficient to conduct follow-up observations every year for all patients after 5 years, especially for patients who are at low risk of recurrence. Therefore, it is recommended that the physician and patient thoroughly discuss the risk of recurrence before deciding on a follow-up schedule. Gender, age, tumor stage, clear cell type, tumor grade, and tumor differentiation were factors associated with recurrence in their study. Those were the findings and recommendations from that recent study. As I mentioned earlier, it is necessary to identify prognostic factors for kidney cancer recurrence after 5 years, either by integrating previously published prognostic factors or by identifying new factors for predicting delayed recurrence. Doing so would enable physicians to better predict the prognosis and be more accurate and potentially be able to develop strategies for longer and more aggressive follow-ups in selected patients at a very high risk of recurrence. However, few prognostic models have been developed to predict delayed recurrence, again, which is more than 5 years after nephrectomy. So, many are not suitable for identifying patients who require long-term follow-up beyond 5 years. The Leibovich model and the Assure model both provide recurrence estimates 10 years out. Take a look at one of those to see what your estimates are and talk to your physician about what that means for you. Based on the research I've done and the recommendations from the top 5 medical centers in the United States for the treatment of kidney cancer, there certainly is a case to be made for ongoing surveillance, imaging in particular, for patients who have had a partial or complete nephrectomy to remove a cancerous mass. That's true too for patients who are considered low risk for the cancer returning, even though it's even on a smaller scale than for patients who are considered intermediate to high risk of recurrence. In all cases, it comes down to a discussion between the patient and their physician as to what that surveillance schedule looks like and how in-depth the testing is at each interval. I will be insisting on periodic imaging through the 10-year mark for sure, given I'm considered high intermediate risk for cancer recurrence. Educate yourself to make sure you understand the risks and benefits of surveillance testing for kidney cancer after the 5-year mark, and have an informed discussion with your physician regarding how to move forward. Thank you for listening. I'm Jeff Callis from the Kidney Couch. Join us next time around the couch.